Please be aware that this podcast has reference to drug and alcohol use and paraphernalia and may not be appropriate for some people in early recovery. Hello, everyone. My name is Dr. Mahjabeen Islam.
And I am Dr. Ketley Daniels.
The information in this podcast cannot replace your seeking a treatment provider, which you can easily do at SAMHSA's national helpline at findtreatment.gov or 1-800-622-4357. So we discussed risky drinking or problem alcohol use in our previous podcast and defined it as drinking so much within about 2 hours that the blood alcohol concentration goes to 0.08 grams per deciliter. In men under 65, it is more than 14 drinks a week or more than 4 drinks at a time. In women of any age or men over 65, risky alcohol use is more than 7 drinks in a week or more than 3 drinks at a time.
And we also said last time that people are using their digits to calculate how much.
Yes, you did. You sure did.
That they were drinking and finding out that they probably are crossing that line. We discussed what alcohol use disorder is in the previous treatment, yes, and how to screen for it. So where do we go from here?
Yeah, and we promised that in this episode we would discuss the treatment of alcohol use disorder. It is first important to determine how serious the problem is, like in anything. We call that the Addiction Severity Index, and that is the same for all substances and alcohol. So it's based on those criteria we talked about that make the diagnosis. It's mild when there are 2 to 3 criteria present. It's moderate if there are 4 to 5. It's severe if there are 6 or more. The most important piece, though, is that whether it is mild, moderate, or severe, recovery is only possible if the person understands that they cannot even have a sip of alcohol. Like we mentioned in our previous episode, even a small amount can restart a full addiction or relapse. And it's very important for people to realize and accept that with addiction, one cannot stop at 1 drink, 1 pill, or 1 shot.
And that is very, very hard for most people to actually hang on to that. But so what are some of the symptoms of alcohol withdrawal?
In mild alcohol withdrawal, usually within 6 to 36 hours, there will be insomnia or tremor, shaking, anxiety, nausea, vomiting, loss of appetite, headache, sweating, and palpitation. It does vary from person to person, but in about 6 to 48 hours, there can be seizures. And as the withdrawal syndrome progresses, there can be what we call alcoholic hallucinosis, in which the person sees and touches things that are not there. And then you see that this is getting more and more severe. And in about 48 to 96 hours of suddenly stopping alcohol, there can be delirium tremens, which includes delirium or a state of lower level of consciousness, agitation, a fast heart rate, high blood pressure, fever, and sweating. And what's really interesting is that in the early 20th century, the mortality or risk of death from DTs was 37%. But with our advances in modern medicine, which is so amazing always, it has fallen to 5%.
Which is awesome. And I was just picturing, there was a gentleman I saw on the unit once, and he was in full withdrawal. It was not a pretty picture. But can we predict that someone is going to or will go through DTs?
It is more common in people who are over 65. And I explain that to patients that, withdrawal is now, if they are 60 and above, is very different from what they could do when they were a lot younger. The elasticity of the body, the response of the body is just very, very different. And we really want to concentrate on the management of mild to moderate alcohol use disorder, because once it develops to the point of DTs, then the patient requires hospitalization.
So how do we approach mild alcohol use disorder?
People are pretty adept at it. So if it is mild, they don't really need any medication. Counseling or attendance at AA or 12-step meetings can work, and we'll talk about that in a minute.
So that's for the mild use disorder. What do we do for those who have moderate or severe symptoms?
So I've noticed that people with alcohol use disorder do very well with naltrexone. I'm very impressed with that as a medication. It blocks opioids, but it has been shown to be very effective. Actually, it was used for alcohol use disorder prior to it being used for opioids. And I still remember a patient of mine who was on Vivitrol, the injectable version of naltrexone, which we're going to talk about, and who had both alcohol and opioid addiction, saying that if they were surrounded with heroin and alcohol, they would not touch either.
So there are two types of naltrexones, correct?
Yes. Naltrexone can be taken as a pill or as an injection, and actually studies show that the pill does not work as well as an injection because obviously the person can stop taking the pill, and that is generally what does happen. But in some situations, like when insurance companies don't cover the injectable, some patients choose to be on the pill.
And certainly the Vivitrol, the injectable, is much more reliable. But for those who are motivated, I've had a couple of people actually respond to just taking the oral naltrexone, so they have to be motivated. Are there any issues with the naltrexone pills, though?
No major issues as such, just that we would do tests on the liver prior to starting the naltrexone and periodically when a person is on it. But in my experience, it's really very well tolerated. It kind of like develops a history that it's well tolerated.
So what's your procedure then in your practice? How do you get it started?
So like we do it with all patients, we do a full evaluation and detailed blood work. And then on the day when we are going to start the naltrexone, we also do a urine test to make sure that the person has not been taking opioids. Because as we talked about, naltrexone is an opioid antagonist or blocker and can put the person into opioid withdrawal.
But in your experience, the injectable form of naltrexone, also called Vivitrol, is a lot more successful, more dependable?
Yeah, and actually, Vivitrol is really a remarkable medication. And once a person comes to the point that they are ready to receive it and they really do quite well. And the way that it works is that the person does not feel the high or the intoxication of alcohol, and so it becomes a waste of time and money and effort to drink.
And I think, though, for you, especially as an addiction specialist, it's good that you're available for those who have the severe alcohol use disorder so that you can treat them when they're going through withdrawal symptoms or delirium tremens.
Yeah, that's very true because the mortality rate of severe alcohol withdrawal, like we mentioned above, is 5%, and it was much higher in the past. And, we do a number of 5%, but it can obviously vary from patient to patient.
Absolutely. It seems clearly that it's important to deal with the alcohol withdrawal in its early stages and to assess which patient is going to need medication to prevent a more severe issue such as seizures.
Yeah, that is really a very, it's kind of like one of those red line kind of things where a very good history and examination are very important. I always ask a person if they have had a seizure in the past, and if they have, then it's important to deal with the alcohol withdrawal and a potential seizure first, and then go on to medications like naltrexone or Vivitrol, which will prevent further use.
So if a person has had a seizure in the past, how do you approach it? What do you do?
So the literature now recommends topiramate or gabapentin, and I have used both and have had particular luck with gabapentin. The reason being that not only does it prevent the seizure, but it also helps with anxiety, and people with alcohol withdrawal or any kind of withdrawal are in a very hyper anxious sort of a state. Topiramate or the brand name Topamax will prevent a seizure, but it does not do anything for anxiety. So gabapentin is like my go-to now. In the old days, we used to use Ativan and Valium and medications which are called benzodiazepines. But because gabapentin and topiramate do so well, we don't use those that much.
And I think also the beauty of gabapentin, in my practice, I use it quite a bit for anxiety disorders.
Yeah.
It works very nicely. I know in your practice you work towards abstinence, but you have an interesting story that I think the audience might like to hear about tweaking the Vivitrol.
Yeah, we work towards the treatment of addiction in the true sense of the word, and for the patient to recognize it as a disease and to work toward abstinence, which is really the philosophical or the principal part of it. But with the development of oral naltrexone and even the injectable Vivitrol, there are people who will take the naltrexone pill and some even the injectable Vivitrol because they do not notice the high of alcohol. And in business meetings, I had this guy who was actually on Vivitrol because in business meetings, he did not want to give the impression that he could not drink. And it really took me a long time to latch on to this premise. And he asked me one time, he said, it's called the Sinclair method. And it's really interesting and how humbling it is that you learn from patients. And I said, the Sinclair method? And he said, he was kind of like a little like that I didn't know about it. Because we go on the philosophy or the principle that, once you are on this medication, you recognize that you're going to have sobriety, you stop using it. So in the Sinclair method, basically the person is on Vivitrol or it started out obviously with oral naltrexone. And it's primarily the intent is that patients continue to drink, but they are not hugely intoxicated and they're still functional because they don't have the high. They're not helplessly drunk.
It works.
It works, and I'm not close to it now.
And you also have an interesting story that you can tell our audience about the elderly patient who was prescribed naltrexone.
It is very interesting because in medicine you see how it's like doing experiments on, guinea pigs. Because we started her on, she was falling and obviously she was older and you were so afraid of a hip fracture. So it was established, the family was telling us. So I started her with her consent on naltrexone and boom, stopped drinking. And it was wonderful. And it was wonderful for several months. Then she wisened up to it.
She caught on. Why am I not drinking?
And then she says, after several months of using it, maybe even a year, she says that I'm having a lot of side effects. I don't want to. And so I asked her the side effects because the side effects of naltrexone are pretty limited. It's like fatigue. And she was like, like she, hemming and hawing. And then I realized that she did not want to be on the naltrexone. And it kind of just proves that you can take a horse to water, but you can't make it drink, which is like the opposite fun.
And I think, unfortunately, there is that psychological connection to the product that they still want to drink. And she missed that
yes,
moment. Yeah, she
exactly,
missed it. Yeah.
Exactly.
There are other treatments, too, for alcohol use disorders, aren't there?
There are, and we have actually grown up in medicine with those treatments, as you remember, of antabuse. But they really are rarely used now, more so used when everything else fails, like naltrexone fails, Vivitrol fails, or doesn't work for the patient, rather. And there's Campril too, but I don't even remember the last time I used it because once the person comes to the point of wanting sobriety, they are they do so well with Vivitrol that I have not had any reason to use Campril. So it would just be someone who did not tolerate the Vivitrol.
I've actually had several people come to my office asking for the antabuse as a deterrent from drinking.
Right.
And so definitely we worked with them on their goals. But I think our episode would be incomplete if we didn't discuss the 12-step program called AA.
More so because it was created by our fellow Ohioans, Bill Wilson and Dr. Bob Smith, in 1935 in Akron, Ohio.
What are the main principles, though, of AA?
To kind of go over it, it focuses on 4 main items. The first being acceptance that there's a problem. And this is a very important thing in anything in medicine or anything that goes wrong with a human being. Accepting a problem is the first step. Then the second is turning our will and control over to God. And the third is doing a moral inventory. And the fourth is making amends.
I have quite a few people who have been sober for decades. We're talking 10, 20, 30 years of sobriety and using Alcoholics Anonymous as their platform.
Right.
And one gentleman, he had issues with number 2, turning it over to God. And he decided to find another source for his higher power.
Yeah.
And he did. And he was quite content with that. The starting piece is admitting or accepting that there is a problem. And this really jives with medicine because we believe that diagnosis is very important. Because if you don't admit you have a problem, you won't seek treatment.
Right. And my favorite step is actually step 3, which says deciding to turn our will and lives over to the care of God as we understand Him. This is verbatim from the 12 steps. And a story that I love to tell my patients, and they really enjoy it because they can, grasp it, is about a little girl who is struggling with a broken toy. And she hands it over to God, and she tells him to fix it. And while he's fixing it, she's yanking at it. And she continues to yank at it. And what's taking you so long? What's taking you so long? And then finally, she loses patience altogether. So she yanks it altogether. And then she looks at it. And then she says, you didn't even fix it. And God says, you never let go. Mm-hmm. And from that, the premise of let go, let God is created. Mm-hmm. And it's really, really an important premise for people with and without addiction. Because giving one's issues over to God or a higher power takes care of that constant anxiety machine that human beings are and that people live with.
And I think also the steps of taking a moral inventory and making amends, that's also very important, because I have many people who have done a lot of damage because of their, alcohol use disorder. So they do have to make amends. Yeah.
And I really sort of appreciate very much people who are very entrenched in the AA philosophy, that they are very into this about making amends. Mm-hmm. And there's a celebrity who is a wonderful example of the success of the 12 steps, and that's author Stephen King. Mm-hmm. He had a drug and alcohol problem in the 80s. And in 1987, his family did an intervention, and now he writes without being in a drunken haze.
Isn't that awesome?
That is.
That's awesome. It's a very encouraging story, but there are issues with AA also in that while there are steps that can be used to save lives, they have some issues with their rigid approach. The main thing for us is that they do not like the idea of using medications for treatment.
And this I really struggle with because they are very rigid about it. And if someone, like we talked about before, if someone has mild alcohol or opioid use disorder, they might be able to achieve sobriety without any medications and just with, attending AA meetings. But patients with moderate to severe alcohol use disorder or opioid use disorder do much, much better with medication assistance, like a bridge, so to speak. Mm-hmm. The issue with AA is that it is so steeped in the original 12 steps that they seem to have been concretized, And I tell my patients, because it has become so prominent that they do not appreciate medications, that we really recommend the 12-step program to our patients. But when they are on Suboxone for opioid use disorder or Vivitrol for alcohol use disorder, I tell them to not let them know in a meeting that they are on medication, because then they report somewhat of a harassing sort of tone of other people. So I just tell them that don't tell them that you are on medication, but just gain all of the knowledge and the great assistance that the 12-step program is.
I have found myself also discouraging sharing extra information.
Yes.
Because, certainly you want to be honest, especially if you have a sponsor, if you have others that you're close to. But you don't have to tell everyone everything that you're taking.
Exactly. Yeah, like TMI, too much information.
That's correct. Mm-hmm. I think from the behavioral aspect, we have the attendance of the 12-step program that works really well, obtaining and maintaining a sponsor with someone who is healthier and has been sober longer than you. And the sponsor does provide support, accountability, and guidance. And I've seen some great relationships over the years. Indeed. But also some people need individual counseling because, again, there's a lot of trauma that led to their alcohol use or relationship issues that has to be addressed.
Yeah, what we call trauma-informed care, yeah. Mm-hmm. There's a fraternity and social support system also that we really recommend. And a celebrity example of this is Ben Affleck, the actor, who credits his recovery from alcohol addiction to fellow celebrities Robert Downey Jr. and Bradley Cooper. They helped him work through the process of recovery. And this is a very key piece in terms of peer support. And as far as the peers are concerned, of them giving back. So it's just a very sort of touching sort of dynamic.
Yeah, I was telling someone that there is it's a verse in the Bible that says the person that waters is himself watered. So the more we give, the more comes back to us. Yes. So this is a good interplay within this 12-step program.
Paying it forward,
absolutely. Continuing the behavioral treatment is one piece, but there is the gradation, because in mild situations we can give medical treatment and advise 12 steps. If there is greater difficulty with recovery, we recommend intensive outpatient program. People will say things like IOP. IOP is a program where you can go in 3 days a week for several hours, for several weeks until you're stable. And if they're still struggling, then we recommend partial hospitalization.
PHP.
It's a day program that they go to sometimes for several weeks until they're stable and they can step down. It seems to me like with all addictions, the person has to want it for these services to actually help them.
Yeah, and I really remember you have to want to.
Mm-hmm.
I really enjoyed that.
Mm-hmm.
And I always tell my patients that if you have the motivation, then we have the treatment.
Absolutely.
We really hope that you are enjoying our podcast series. Please subscribe and share the podcast with family and friends. You can listen on wgte.org/treataddiction or anywhere you get your podcast. Just search for Treat Addiction. It is only through awareness and education that we can tackle the very treatable disease of addiction. I want to thank my co-host, Dr. Ketley Daniels, for a great discussion today. I'm your host and producer, Dr. Mahjabeen Islam.
And I am your co-host, Dr. Ketley Daniels.
And our executive producer is Chris Pfeiffer. Until the next episode, do remember, patience in difficult times and gratitude always. Let's meet again soon.
WGTE. Voices around us.
WGTE is supported in part by the American Rescue Plan Act funds allocated by the City of Toledo and the Lucas County Commissioners and administered by the Arts Commission.